Well, now you're in for a treat. I'd like to introduce a physician leader who's been advancing the case for and the cause of population health for decades. As you'll hear, population health is his secret sauce. For us, it's the glue that increasingly is going to connect St. Luke's and our communities. It's part of our strategic framework. It's that important. It's also complex to implement, and it can be confusing to understand, which is why it's so important to talk about and why we have brought the leading expert in it here to talk to all of us today. Dr. David Nash is internationally recognized for his work in outcomes, management, medical staff development, and quality of care improvement. He is a tireless champion of improvement in outcomes and safety, a prodigious author and speaker, and a blogger, a man after my own heart, like that, and an outspoken advocate for the types of change that St. Luke's is pursuing. In your materials is his biographical information, so I'm not going to go through everything because we want to get right to his presentation. So if you would, help me welcome Dr. David Nash. Thanks. And if you need the pointer, use the green.
Great. Well, good morning. Thanks very much, David. It's easy to remember. David, that's easy. So it's really wonderful to be here. So I have never been to Idaho. So how awesome is this, right? To get to come to Boise. So for the last 22 years, 24 at Jefferson, I've been traveling back and forth across the country. My physician wife early yesterday said, "Are you going to a place you've never been?" I said, "Yes." She said, "Well, that's like amazing. There's a hospital you haven't been to?" I said, "Yes, there's a whole state I haven't been to." So it's really a thrill to be here. And later I'll tell you about our secret connection between David Pate and me. But I am thrilled to be here. Let me tell you a little bit about the genesis of today. So Courtney on your team, she and I started our long-distance romance on August 14th, 2013, to get to today. In fact, my wife was beginning to wonder, who is Courtney? Because of all the communication that we had. But seriously, I am thrilled to be able to come to St. Luke's. Let me give you the punchline. You're well on your way. In fact, I have a hard time thinking of a place that has really moved the ball down the population health field, if you would, as far as you have been able to do it. In other words, my British friends would say this is a little bit like bringing coals to Newcastle. In other words, the last thing Newcastle needs is more coal, but you get it. So my job today, I'm your setup guy. So I'm going to give you the big picture. I'm going to make it a lot easier for both your internal speakers and Mark later today. So you're going to have a wonderful day today and tomorrow. So my job is, how do we get in this jam? What's the big picture? Are you on the right road? And at the end, look around the corner and give you Nash's twisted view of where I think we're headed. So here's how we're going to do this, and I'm under no time pressure, which is wonderful. So we're going to do 4 things. Part 1, how do we get in this jam? Because we have an eclectic audience, and what David didn't specifically tell you, for all the board members in the room, in fact, if board members, would you raise your hand just to help me out here? Okay, great. Awesome. So, I feel your pain. So 10 years on the board, the corporate board for Catholic Healthcare Partners in Cincinnati, 5 states, 40,000 employees, 30 hospitals. So I did 6 trips a year from Philadelphia to Cincinnati times 10 years. That's 60 trips to help Catholic Healthcare Partners begin to grapple with some of the issues, of course, you're way ahead on now. And I'm currently on the board of, and I left that after a decade, and now I'm on the board of Mainline Health Systems, a 4-hospital community system just outside Philadelphia, where I chair the board quality of care committee. So board members, I get it. And I really do, I think, have a visceral appreciation for your hard work. And based on what I saw of where you're going, you have a lot more hard work coming your way too. So I really do appreciate that. So part one will be, how do we get in this jam and what is all this stuff anyway? Since we have an eclectic audience, I'm going to give some definitions and try to lay the groundwork for how did we get to February 2014. Part two, I've got to define population health because it's not clear what we all mean by population health. And since I'm the dean of the only school of population health, I, of course, have the right answer. Part three, we got to talk about health reform as it relates to improving the health of the population. And then finally, part four, I'm going to show you a picture of my family, and then I'm going to predict the future. So there's no future in predicting the future, but we're going to do it anyway. All right, for the internists in the room, here's the review. Part one, how do we get in this jam? Part two, what's population health? Part three, health reform. Part four, where are we going? Okay? Really important. Thank you. Finally, 1 or 2 minutes of shameless advertising so I don't forget. So since I came all the way to Boise, I expect many of you to come to Philadelphia in just a month from now, March 17, 18, and 19. Seriously, our brochure is out there. We're expecting over 500 persons. I have every national leader in our field, and I'm not exaggerating, will be at the Loews Hotel, downtown Philadelphia for 3 days in March. I really hope some of the leaders will be able to join us. Public and private, not-for-profit and for-profit, infamous and famous, will be with us for 3 days talking about their vision. The president of Humana, the commissioner of health for the state of New York, the CEOs of some of the largest not-for-profit systems and some of the largest for-profit systems will all be with us for 3 days. I really, really hope some of you will make the journey, and it'll be a lot of fun. Okay, so let's make sure the technology is working, and let's see. That's always a good sign. Okay, great. Well, once again, special thanks to Courtney. In fact, can we take a minute, a round of applause for the team that made it all possible? You know, it looks easy when you're all in a beautiful room like this on a lovely Friday morning, but believe me, I know how much hard work goes into this. Okay, a little bit of geography. So this is the floor of our gymnasium at Thomas Jefferson University. We are not in Virginia. We're in downtown Philadelphia. So Jefferson is one of our nation's 141 academic health centers. In other words, medical school, and a big hospital. And our place is unique. Of the 141 academic medical centers, 7 look like Jefferson, which is, this is the gymnasium, home of our undefeated basketball team. That's because we don't got one. So we don't have any pesky undergraduates, no law school, no business school. All we do, health is all we do. That's our tagline. So there's 6 schools, you can sort of figure it out, right? Jefferson Medical College, the largest private medical school in the United States of America. Nursing school, pharmacy school, allied health, graduate school of science, people silly enough to get a PhD in microbiology. And the School of Population Health, the school I am very privileged to lead, which is 4 years old. Much more about that later. And of course, our 610-bed university hospital. So that's Jefferson. More importantly, Philadelphia, birthplace of our country, you know that. 3 blocks from my office is America's first hospital, which is called what? America's first hospital. Anybody? Washington, Pennsylvania Hospital, of course, founded by? Now listen, any question about Philadelphia founded by, the answer is Benjamin Franklin, come on. So 3 blocks from my office is America's first hospital, right, of course. America's first medical school hospital, our arch rival, the Hospital of the University of Pennsylvania, there I said it. 20 blocks west of us. Home of the American College of Physicians, the National Board of Medical Examiners, the American Board of Internal Medicine, 4 of the nation's largest private medical schools. 1 out of 4 doctors passes through Philadelphia in the 21st century at some point in her training. Right? Because on average, America's medical schools are 52% female, a major social revolution, which is going to play out in Boise, Idaho. More on that later, too. So have I convinced you that Philadelphia is the center of American medicine and not that silly city on the banks of the Charles River? Okay, mission accomplished. Okay, so what David was really saying is this, right? You know, here's the BlackBerry. Raise your hand if you're still using one. Yeah, we got one or two. One or two. That's good. That's good. That's why he's retiring. He can't face an iPhone. Right. So I got a phone call 3 weeks ago at Jefferson. We have 1,500 university-supported web-enabled phones. 57 of us were left on a BlackBerry of the 1,500, and I was told I have to give it up. I had withdrawal symptoms, but I finally adapted to the iPhone. So I love this Bloomberg Business Week cover story because, you know, how the BlackBerry became a relic. It's exactly the same kind of thing of how Jefferson and St. Luke's could very rapidly become a relic if we don't adapt and adopt to the New World Order. And, you know, we always, as a society, overestimate change in the short term, and underestimate in the long term. And that is the risk, the balance, the tension that we'll be talking about throughout our time together today and in the question and answer. So I'd love this brand new cover story, how it became a relic. Just put a university hospital up there and we could really rapidly become a relic too. Okay, so whatever your politics here in the great state of Idaho, you know, I ain't interested. It's okay, whoever you vote for, no problem. But the tactical reality is, you know, we haven't felt the pain yet. No cardiologist has had a 15% decrease in his income yet. No orthopedist I know is unable to make a mortgage payment yet. So the pain level is not high enough yet to convince all of us that this is the right direction. But folks, here's a little bit of background. So our great country spends more on health care than any nation on the planet. You and I know that. And what do we get for the money we're spending? Everywhere but St. Luke's at Jefferson, what do we get? So we're number 17 in the world, just behind Slovenia, with regard to the quality of life of our society, based in no small part in the investment in healthcare. In other words, we're spending the most, and the value that we're getting for the money we're spending is quite questionable. We'll come back to that theme. So this is going to hurt. Yes, it will. And also, you know, I love this picture because, you know, he has a long, thin face. Look at the size of that syringe. And I can't tell whether the president is a surgeon in this picture, a pain therapist, but whatever it is, it's going to hurt for sure. But we haven't felt the pain quite yet. Sure, all the confusion about exchanges, that's not what I'm talking about. I'm talking about the real fundamental shift from episodic and acute care to improving the health of a population. And that's a big part of what today and tomorrow is all about. And of course, we'll come back to those themes. So nothing illustrates this transition better in my mind than this exact citation that I stumbled on in the research to one of our books a number of years ago. And you could read along with me. All integrated delivery systems like Jefferson and St. Luke's are accountable to the public for their degree of success. If this initiative isn't taken by everybody in this room, it will be taken by the lay public. This was a century ago, 1918, unbelievable. What's even more unbelievable, a bunch of surgeons wrote this. That's a joke, you understand that, yeah? So this is a direct citation from the inaugural meeting of the American College of Surgeons during the First World War at the famous Waldorf Astoria Hotel on Park Avenue, Midtown Manhattan, a century ago. So we're going to come back in the fourth part of our time together to connect the dots on transparency and public accountability, because a big part of being accountable for a population means total transparency on outcomes. We're going to hit those themes. So you should be thinking in the back of your mind about the themes of transparency and public accountability. And I'm a big proponent. If we don't do this, then we deserve the pain we'll feel under reform. In other words, it's up to us. As ridiculous as that is, it's totally up to us. And we'll come back, board members most especially. This is an important message. Okay, so some of the tactical realities, getting into part one together. So you have read all about this. Maybe you've not read the Physician Executive Journal, but we're moving from a world of volume, more is better. I have spent my whole professional life in two temples of technology, the University of Pennsylvania and Jefferson University. Two temples of technology built on the platform of what? More is better, more of everything. More parking spots, more caths, more open heart surgery, more endoscopy, more faculty, more drugs, more research, more students. More is growth, and growth is good. And now we're saying, wait a second, maybe that fundamental model for 30 years is broken. That's where we're at. And now maybe we have to move to a world of, well, volume's important, but we want to know the outcome of what we're getting for the money we're spending. Why is the United States at number 17 right behind Slovenia? This is a powerful social movement, not just a business issue for you and me. So this illustrates this move from volume to value. Here's another way of looking at it, but this is actually even more subtle. So we've been pretty good, and I know I have members of the quality improvement team here. We've been pretty good in measuring and improving what we do every day. Certainly our school has been at the forefront of aspects of this. My first book on quality is 20 years ago. So we've become experts at the checklist for performance. Did you order the hemoglobin A1C? Did you get the eye exam for the diabetic? Check the box performance measures, process measures in our technical language. Board members, you've seen all these process measures over the years. Now we're in a new world order of, well, all those processes are important, those core measures are important, but what are we, at the patient level, are the results better? Is the hemoglobin A1C improved over last year? Not the fact that you measured it. Is it in the right direction? Now, you may think this is semantics. It ain't. This is a different way of looking at how we're delivering care and the outcomes of that care. So that's why Managed Care Magazine a year ago said, well, it's not just pay for performance. That's relatively straightforward. Now we want payment for results. And we'll come back to that theme as well. Okay, so this is a slide I stole from the CEO of Baycare in Tampa, Florida, because I thought it was so great. So here's a hapless intern, and he's sort of balancing on these two canoes. And the one canoe with this red REI backpack says, historical and current fee-for-service. And the other backpack, of course, is the one we're here talking about today, value-based performance and population-based care. And he's balancing between these two canoes so he could sail down the river in this canoe. What he doesn't know is 200 feet downstream is a 1,000-foot waterfall that he's going to fall off the canoe and perish. He could always just jump into the water and give up. Most physicians I know, 55 and over, when I'm done talking, come up to me and said, I just want to live another 4 or 5 years in the work world. Get me to that point, right? I get it. I get it. I'm sure you have a few of them in your system too. And then there's the righteous path and the other canoe sailing off to value-based, population-based care. And that's in part what the whole day today and tomorrow is all about. And I've simplified it, obviously, but now we could get into some of the details. Before we can get into what's population health and health reform, you're going to have to suffer a little bit with me. So here's a famous Business Week cover story, now called Bloomberg Business, but you get the idea. You could read the headline here. Medical guesswork from heart surgery to prostate care. They get that in there all the time. The medical industry knows little about what really works. What's this all about? Well, the doors are closed. We're among friends. There are no, outsiders here. So what's this about? Well, this is about what most doctors know, but difficult to admit. 18% of the time we have grade A evidence as to what the hell it is we're doing every day. 18% of the time, on a good day. In other words, 1 out of 5 clinical decisions at the bedside, in the operating room, in the office, we have solid science. The other 4 out of 5 decisions, what do you and I call that? We call that the art of medicine, right? I mean, that's okay. Far be it from me to condemn the art of medicine. A bolt of lightning will come down and strike me. But from a perspective of the employers who pay 52 cents of every dollar spent on healthcare in our country, that's how you end up with a magazine cover story which basically says, what am I buying? Can I get greater value? Can it be safer? These are the issues that large employers all across the country, even here in Boise, are asking. Can we achieve a greater value for the money we're spending? The absolute answer to that question is, of course we can. And I'm going to show you what it might take to be able to do that. So this is all about what we call unexplained clinical variation. For board members, that's probably worth writing down. The 3 words that describe the core of our current problem: unexplained clinical variation, which is a complex social system where doctors are taught these kinds of things early on. And we'll, in the question and answer, I want you to ask me more about unexplained clinical variation. That's the root of all evil in our system, and driving overutilization, poor outcomes, and it's not safe, just to name a few things. So the people who pay the bills, they're on to us, large employers and insurance companies. That's another part of our problem. I want to give you 2 references that if you have an opportunity to read, it'll really depress you. Here's the first one. This is called Mirror, Mirror on the Wall, June 2010, available online from the Commonwealth Fund in New York City. Details not important. Main message, we're not getting value for the money we're spending. Maybe in oncologic care, because our country spends more for the care of persons with cancer on a per capita basis than any other nation in the world, even by a higher margin than any other service. And the second report's got a really important name called Poorer Care. It goes like this. Sicker Care, Poorer Outcomes. And this is from the Institute of Medicine, January of 2013. So this is 2010, 2013. Message is the same. We're not getting value for the money that we're spending. And this is such a sad part of the underlying issue. So I want you to be thinking when we talk about reform, is the Affordable Care Act really designed to fix what's broken? That's not just a political question. It's an important strategic and tactical question with a complex answer. So will it fix this disparity? Will it really promote population-based care? We'll come back to that when we talk about population health. Main message for board members especially, we ain't getting value for the money we're spending. Okay. From a clinical perspective, and we're going back and forth here on purpose, from a clinical perspective, we have some other major challenges. Now, I know this doesn't happen at St. Luke's, but everywhere else, this is a huge issue, which goes like this. Classic work by Elizabeth McGlynn and her team at the RAND Corporation a decade ago, and follow-up papers in the New England Journal of Medicine, but here is the classic piece. When she examined what we actually do at the bedside, in the hospital, in the office, and so on, and compared that against the best available research evidence, in other words, these quality indicators, when based on hundreds of hospitals, thousands of patients, largely in California, now a decade ago, but subsequent papers have borne this out. If you believe the best research in our best journal, if you believe that, she says we get it right on average a little bit more than half the time. Now let that hang in the air for a moment. So before we can move to improving the health of the population, we have some blocking and tackling to do inside the hospital, inside the office, which would argue we have a lot of work to do before we can even take on economic risk, become a functioning ACO. More on that later. So part 1 is designed to deliberately make you uncomfortable that the platform, the foundation, whatever you'd like to call it, is shifting, has some cracking concrete, has a couple of loose nails. We have work to do still before we can achieve the vision of improving the health of the population. Elizabeth's work is one of several out there, of course. By the way, Elizabeth now is the Senior Vice President for Outcomes at a small outfit called Kaiser Permanente in California, where she's bringing this same mindset to their population engine that they've been working on since the Second World War. So we have a lot to learn about those kinds of delivery systems, and again, more on that later. Let me illustrate this for the non-clinicians in the room. So atrial fibrillation is a disordered heart rate, can be fatal. You need to be on blood thinners. It's a complex thing. Lots of elderly people get it. So when my late father was 80, he had atrial fibrillation like a lot of older, overweight men, probably idiosyncratic. He never really had coronary disease. Anyway, I put my cardiologist kid brother and my cardiologist uncle, my father's kid brother, in a room in Florida together. And I said, don't come out until you tell me how we're going to treat Dad. 6 hours later, they were still arguing. As just one example, just one. And we could go on, and all the doctors in the room know exactly what I'm talking about, because that's the art part of medicine. The challenge with the art is the people who pay the bills for what we do are not connoisseurs of great art. And in there lies a big part of our problem. More on that as well. Okay, so again, we're still pretty tactical. We have a lot of work to do still inside Jefferson and inside all of your delivery system, because for the first time in a peer-reviewed journal, way back in 1998, Don Berwick, one of the high priests of our movement. By the way, do you know that Dr. Berwick is running for governor of the People's Republic of Massachusetts? And he's soliciting campaign contributions. You know, 5 years ago, I could never get Don Berwick on the telephone. Now he's calling my cell phone on a regular basis. Oh, my God. Anyway, back in 1998, he said, it's possible to improve care and dramatically lower costs. 16 years ago, first time ever in a peer-reviewed journal, this happened to be Annals of Internal Medicine. So what was he thinking about? So I want to just hold this for a moment. So, you know, for doctors, this is a wait a minute moment. I don't get it. How can you improve care and lower costs? You get what you pay for? Well, no. That's really the core issue here, that one of the major ways we can improve what we do and lower costs is, of course, making care safer. So here's the Institute of Medicine list, right? This is the June 2011 report that stands behind the 1998 contention that Don had. The proof is in the research, and the research says the number one way to improve outcomes and lower costs is, of course, what? Reduce unexplained clinical variation and prevent harm. Board members, listen up. You're in charge of the quality and safety of care. Not David, not any single staff doctor, not the president of the medical staff, not your chief medical officer. The buck stops with you. If that doesn't make you have ants in your pants, I don't know what will. You're in charge of quality. You're in charge of safety. When someone's hurt, it's your fault. That's how you approach the quality and safety agenda. So I know you never have any inpatient errors at St. Luke's. I know you'd never harmed anybody. But this is your number one job. Number two job, now we can get into the details, you know. Let's prevent avoidable hospital admissions. What exactly does that even mean? If we do that, we're going to hurt the bottom line right now, but maybe 3, 4, 5 years from now, that will be the new economic model. Oh boy, we're going to turn the battleship around inside the Panama Canal. That's really what we're trying to visualize here, right? Prevent avoidable readmission. Well, we're pretty good at that now. How come? Well, we got an economic incentive to do so. Your chief financial officer, he's going into the emergency room. He's looking for that decubitus ulcer. Excuse me, did you have that when you came in? Right? And it's okay to be readmitted as long as it's after those 30 days. Come on back, come on back. That's okay. So we're making some progress because we had an economic incentive to do so. What I'm arguing is way broader. What I'm arguing is it's your fiduciary responsibility as the board to ask the difficult questions about every single thing on this list. That's a hard job. Try doing it across 5 states in 35 hospitals. I would lay awake at night during my Catholic Healthcare Partners service, nervous. How could I possibly know what was going on in Paducah, Kentucky, right? So this is part of our world moving forward. Okay, now we can give a definition for quality. Here it is, 1991. Let's frame it up. So Brent James and others wrote this, the Institute of Medicine work, 1991. It's like ancient history. But it's got 3 surprisingly important and current core tenets. We'll go over them together. So the degree to which health services for individuals and the population, there it is, 1991, kind of a, harbinger of where we are today. Part 2, increase of the likelihood of a desired health outcome means we actually have to ask patients what's important to them. Holy mackerel. Do we get paid to do that today? Colleagues, do we get paid to ask patients what's important to them? Not on your life. I'm a poor primary care general internist, still seeing patients only in the office. I gave up my inpatient cleats 6 years ago when I became dean. So the core tactical reality is if I asked patients, excuse me, Mrs. Jones, 8 o'clock Monday morning, what's your desired health outcome? That would shoot the whole morning. So I ain't going to ask her. And I don't get paid to ask her anyway. I mean, I can say that and you're giggling, which I appreciate, but wait a minute. So in part 4, we're going to have to learn how to ask, what's your desired health outcome? And maybe, hopefully, get paid to do so. So part 1, population, that's important. Part 2, desired health outcome. Part 3, consistent with current professional knowledge. That's our secret code for we're going to practice based on the best available evidence. Not easy. We don't even know sometimes what the evidence is. In fact, we only have access to it typically 1 out of 3 times. We'll come back to it. So this is a tough definition. 1991, still the most available, most widely used. Okay. I'm assuming every board member's read this book. If you haven't, shame on you. 1999, Bill Clinton holds this book up in the press room of the White House. 1999 is ancient history, pre-9/11, an innocent era. Remember the peace dividend? Imagine that. So the president holds up this book and says, exact words, I commit my administration to reducing the epidemic of medical error. New England Journal of Medicine, 3 weeks ago, Yang et al. How we doing? D. That's our grade. C plus if you're an easy grader. D, 14 years later. Are you kidding? 15 years almost. So this is still pretty darn important. You ain't going to practice population-based care till you lick this. So that's why we got to go through the pain of this. Here's what the public sees, just so you think that they don't read this. Here's Marty Macary's book called Unaccountable Care that got a page 1 B-section review in the Wall Street Journal just about a year ago. How to Stop Hospitals from Killing Us. That's a kind of an upsetting story. Or how about this, my favorite Time magazine cover story of all time. What doctors hate about hospitals. Raise your hand. What's this story about? Anybody, help me out. This is the audience participation part. This is like my Oprah Winfrey act right here. Come on. Raise your hand. Anybody, what's this about? What doctors hate about hospitals. Front page Time magazine. What do you think? Board members, help me. Come on. You guys are super smart. Did you have not enough caffeine this morning? What's this about? It's an important moment. Say it again. Mistakes. Very good. You guys are super smart. What doctors hate about hospitals? Being a patient in one. That's what this is about. 8 physician families egregiously harmed from a preventable medical mistake, including Don Berwick's wife at Man's Best Hospital on the banks of the Charles River in Boston, when her 8 neurologists couldn't figure out what was wrong with her. Ordering different tests and different procedures, not talking to each other. Sound familiar? Right? So we got a lot of work to do. I don't want to be the soothsayer of doom and gloom, but we can't practice population-based care until we tackle some of this stuff too. Okay, good news. We know what works. We know what works. We've done a huge amount of work in the last 2 decades. Our school is one of 4 master's degrees in healthcare quality and safety in the country. I have 50 doctors from all over the country online with me at this moment from 26 states. learning the core tenets to get a Master of Science in Quality and Safety. Now, one school ain't going to fix this problem. 4 schools aren't going to fix it either. But the notion that in a partnership with the American College of Physician Executives and other stuff we'll talk about in the question and answer period, we are making progress. By the way, the number one way still in 2014 to improve quality and safety is wash your hands. My God, right? So I won't ask, David, what's your medical ICU hand washing rate? That's a number the board should have memorized, right? I mean, what could be more important than that? Something your mom taught you before you went to kindergarten. And yet at our place, we're super excited because our hand washing rate using secret shoppers and medical students doing direct observation with a hotline. Dr. Nash didn't wash his hands. We're getting there, 85, 87%. 4 years of gut-bustingly hard work. Okay? So again, blocking and tackling, pretty darn important. Okay, here's the other book every board member had to have read. Crossing the Quality Chasm, 2001. So to Errors Human, 1999, Crossing the Quality Chasm, 2001. What did this book do? The same people who wrote the Affordable Care Act in the basement of the old executive office building next to the White House wrote this book. That's the take-home message. And what'd they say? Well, there are 6 domains that describe care, and this is going to look super familiar to all of you because your plan looks to me to be largely based in part on the 6 domains, which is awesome. The first slide that David showed this morning, to me, resonated. Basically, those are the 6 domains baked into your strategy. So let's quickly review what they are, right? Care's got to be safe, number 1 priority. Will care ever be error-free? No. What's the goal? Care's got to be harm-free, right? It's never going to be error-free because we're dealing with people. Care's got to be harm-free. Care's got to be effective, patient-centered, timely. In Philadelphia, equitable is a super important issue. And, of course, efficient. These are not just, any kind of adjectives. This is a core component of what all care's got to be like, something our nation needs to strive for. Not in Boise, Idaho, but in Philadelphia, the issue of racial and ethnic differences in their access to care, how we treat people of color, huge problem nationwide. Not making light of it here, but clearly a big problem in the major population centers. So care that's effective means, hey, we got to base it based on good evidence. You can't do that test. That test doesn't make any sense. Or doing that test 4 times probably isn't smart, right? And the hospitals with portable MRI units parked in their driveway that doctors own probably don't make too much sense. We could go on. So my 85-year-old uncle was prescribed a simvastatin for his elevated cholesterol. So, you could argue this is 1-week-old information. I have family permission to tell this story, just to illustrate what we're talking about here. So my 85-year-old uncle lives in Florida, ground zero of Medicare overutilization, zip code 33437 if you want to know exactly. That's Boynton Beach, Florida. Don't go there for medical care. The sun is fun, the water's nice, the beach is great, but don't get health care there. So this 85-year-old uncle got placed on a statin for a borderline high cholesterol. We could argue primary prevention for an 85-year-old. What were they thinking? But okay. Then he got leg cramps, which is a known side effect. And without taking a really complex good history, the doctor then put him on narcotic analgesia for the calf pain he was suffering from the drug he probably didn't need in the first damn place. How about my 91-year-old father-in-law who goes to a mainline health hospital where I'm on the board for his annual visit and some knucklehead orders a PSA test on him? This is like Late Night with Conan O'Brien, right? Right? I mean, can you believe it? How about, okay, we'll do one more because there's got a couple of people still frowning in the front row. So my mother just had her 85th birthday on Valentine's Day. Is that the sweetest thing ever? Yeah. In calendar year 13, she had 3 CAT scans for her hiatal hernia. Now, board members, you should never have a single CAT scan for a hiatal hernia. She had 3. And of course, there's a core message in here. Why? Well, Dr. 1 ordered it because mom had substernal chest pain and this squirrely thing, and she's had it for 40 years, but he didn't take a detailed history. And then she didn't like him that much, so she went to another doctor who she thought was way more handsome. He ordered a second CAT scan. Did he ever talk to the first doctor? No. Why should he? Why should the second doctor call the first doctor? Is there any compelling economic reason to do so? What's the answer? No. In fact, you could argue waste of time. By the third one, she went to a third doctor because an aunt of mine told mom that he was really good. So, of course, there's a little bit of doctor shopping. That's what people do in Florida. They go to the doctor. It's part of the culture. But I'll close on this real story by asking you the question, who paid for those 3 CAT scans? Everybody? Audience participation, you all paid. That's exactly right. So, whoa, the 6 domains, super important. Okay, so now we're ready for part 2, right? Because you just can't slam into population health. I mean, you got to know where you've been to know where you're going. You're only going to improve what we measure. So you better pick what you're going to measure pretty carefully. That's the theme. So we're going to answer in part 2 a couple of questions. What is all this stuff? Where did it come from? How does our school interpret it? Not that we have the only answer, although, I like to think that, not probably accurate. And what's the etiology of population health? So here's the message. The first time we could trace the term in the peer-reviewed literature is 35 years ago by Dr. David Kindig, still alive and working at the University of Wisconsin in Madison at their Institute for Population Health. He coined the term population-based care 35 years ago. So this ain't a new term. Here's Trustee magazine now almost 2 years ago, right, summer? First time it was a cover story, so trustees, you've heard about this, and our school was featured in this cover story piece. So here's the definition in kind of 3 easy-to-digest pieces. And this is Kindig. If you'd like the reference, please go online, Kindig, and you could drill deep into David's work. It's really fantastic. But basically, population health says the following, that there are health outcomes, and they're distributed within a population, and some of the measures of those outcomes could be morbidity, mortality, or the one that I've given to you this morning, number 17 in the world after Slovenia with regard to quality of life. Part 1. Second part says, well, that there's certain determinants that influence this distribution. And those determinants include medical care, for sure. That's 15% of the story. So St. Luke's and Jefferson, we contribute 15% of the story with regard to the determinants that drive the outcomes that contribute to the quality of life. I'll show you a picture in a minute to clear all this up. And the other determinants are socioeconomic status, crime, pollution, smoking, behaviors, and my favorite, of course, is choosing your parents wisely. Really important. The third tier sort of says that policies and interventions influence these outcomes, like the Affordable Care Act. So let's simplify all of this and give you a picture. So it's basically a diagram of what I just said, but here's the take-home message almost for the whole morning. Here we are, you and me, in our work role. Medical care is 15% of the story. The other 85% is this messy stuff like poverty, drug abuse, out-of-wedlock pregnancy, smoking, obesity, pollution, no place to exercise, can't afford fresh food. I mean, on and on we go. Violence. Let me give you some examples. Philadelphia, 6th largest city in our country. In the nation's top 10 cities by population, Philadelphia is the poorest. That's right. So the founding fathers never could have anticipated that Philadelphia, fifth or sixth largest city, but in the nation's top 10, the poorest on a per capita basis. 500,000 children go to sleep hungry in our great city every night. Our school system is failing. The Eagles did not make the playoffs. Right? 25% of adults still smoke cigarettes, national average hovering 16-17%. Right? Okay, I could keep going. It's depressing. Half of all school children in the public schools, K through 12, are obese. Half. Now that's a population health time bomb that you and I are going to pay for. So medical care, the episodic, acute, and chronic laying on of hands, that's 15% of the story. The other 85% is what you're trying to do in your community and what we're trying to do in a way more complex environment. What's our community in Philadelphia? People go to 45 zip codes when they leave our front door. So population health in a nutshell is, a big job. If health care, the actual laying on of hands is the 15%, the population health agenda is the other 85%. Now, that was a great slide that you showed that Mark Chasson drew for you and was shown by your chief operating officer, right. So the intervention, do you want to do bariatric surgery? So we've got a huge bariatric surgery department with all special lifts to get the 500-pound people on the operating room. And we have some wonderful surgeons with good outcomes because they have a lot of volume. Is that the answer? Gosh, I hope not. But that's what we get paid to do. Philadelphia, 4 medical schools. We've got 3 helicopters that race to the Schuylkill Expressway to snack up the trauma victims. We have 3 cardiac transplant centers, not a one of which makes its Medicare minimum national average number of cases. We have so many open heart surgery programs, I've lost count. Should I keep going? We have 3 National Cancer Institute programs supported by your tax dollars in our town. Sure, they do great research, I get it. But I'll show you some data in a minute, you'll be scratching your head. So the population health agenda, this is like, it's almost un-American, right? Do we really want to get into this together? Poverty, drug abuse, racial issues, education, what does that have to do with healthcare? Well, the answer is everything, moving forward. So this is the sea change. Are we ready for it? We'll get to that in part 4, but this, don't kid yourselves, this is the sea change that we're bumping up against right now, and some of it is, a head-on collision. Let me give you some more background. So this is a slide deck that we used from a webinar with this fancy consulting company in Chicago called SG2. Details not important. Board members, there's a couple of take-home messages in here. So lots of places, not yours, but lots of places that I visit say, we're ready to do population health. Let's just, jump right in. Well, I would argue, like we did in this webinar back in the fall, the vast majority of health systems don't have the operating scale, the cultural characteristics, a sophisticated delivery model, partner availability, systems in place. I mean, it's not like you're going to throw a switch to do this. And yet, you're in the right direction, reorganizing your governance, getting organized with your community partners. You're in the right road, no question. But let's not kid ourselves. This is going to be gut-bustingly difficult, hard work. And let me drill a little deeper, and you'll see why. Okay, so when we opened our school 5 years ago almost, I realized, we don't have a textbook. How could you have a school without a textbook? Makes no sense. So we're already in the 2nd edition of our book, Population Health, Creating a Culture of Wellness. When this book first came out, now almost 3 years ago, my then hospital CEO, a good longtime pal of mine, said, wait a minute, David, did you have to put that on the cover? right? Creating a culture of wellness. What did that mean? Fewer admissions to the hospital, of course, right? So this is the cultural disconnect. Here's our scholarly peer-reviewed journal. So I'm not going to ask for a show of hands of who here reads this, right? By the way, the title to this journal, Population Health Management, we've had for a decade, even though reform is 2010. We've been at this way before it was popular. So board members, who reads Population Health Management and reports back to you about the latest findings nationwide? I'll let you ponder that later in the day. This is a handout available to you at the front desk from the Governance Institute. This is basically, don't tell anybody, this is the Cliff Notes for the textbook. 6 pages is all you got to know. 6 pages, all summarized, the whole textbook. Don't tell any students I said so, but it's all in there. Group we work with, not responsible for this report, but I wanted you to see the subtitle, right? A Healthier America 2013. This is a year-old report, but read that subtitle. Strategies to move from health care, from sick care to health care, right? That's the punchline. How are we going to do that? Realign the economic incentives, practice based on the best available evidence, ask patients what's important to them, engage with the community. I'll give you a whole list of what we got to do. Now, back when David, Pate, and I, and Courtney, and I read your strategic plan weeks ago, you get it. And connecting to the triple aim is a laudable strategy. And I applaud you for doing it. And it will get you where you need to go. Among the challenges we have are, what are the right measures that will promote the triple aim? So board members, I think in your early tenure post-reorganization, among the challenges that I think would be fun to engage with you more would be, well, what exactly are the measures to demonstrate success in implementing the triple aim? One more time, what are the right measures to demonstrate implementation of the triple aim? At this moment, I don't have the answer. I have some ideas, and certainly our colleagues Matt Stiefel and others who wrote this report have ideas. We published the executive summary of this report in our journal because I was so taken by the notion of connecting the triple aim to population health. More on that in the question and answer period. For our public health colleagues in the community in Boise, what they resonate with is this, the leading health indicators or where we're going to be in 2020. Population health indicators for 2020. So can we connect smoking cessation, obesity reduction, nutrition counseling, all of the goals within Healthy Nation 2020, public health speak, can we connect that to population health? And I'll show you a picture of this in a little while. So these are the kinds of reports that are important. Now I know that you have leaders too, and I'll show you, just hold on, this is a lot of fun. Okay, so I stole this from Sue Denser at the Robert Wood Johnson Foundation. This, of course, Michelangelo's David. This is the American version of his famous sculpture in Florence, Italy, right? I mean, spectacular. So let me show you what goes behind this, which is kind of cool. Okay, so we'll do another audience participation. Hopefully I'll have more traction than I did earlier. So if you know the answer, don't scream it out, but this is, again, take-home message. So what percentage of adult Americans do all 5 of these things? They quickly go through them. Exercise at least 20 minutes 3 times a week. Don't smoke cigarettes or cigars. Eat their fruits and vegetables like their mother taught them. Wear a seatbelt. And number 5 will say are close to an appropriate body mass index. All right, so raise your hand. You got to do all 5 things. What percentage of adults, whole country, over 18, give me a number. What percentage do all 5 things regularly? Raise your hand. 10%. 1%, 7%. Okay, drum roll, hold on. Okay, the answer is 3%. Okay, so let's take a moment to sort of think about this from a population health perspective, right? So I know you're in a Medicare shared savings plan, so you don't have too much downside risk, which is great. So moving forward, do you want these people in your accountable care organization? I mean, important, well, Yes, if you could manage the margin, you'd do okay. Good point, right? So here's our culture. Our culture is we're going to take our simvastatin on the way to McDonald's. Part 2, the government should pay for my simvastatin. I'll buy the Big Mac. That's our culture currently. And, we're going to be colliding with this in our accountable care world because you're going to get down and dirty with these behaviors that drive a huge part of the health of the population. So, again, a lot more on this we could get into in the question and answer. So let me show you some other things. So if I made rounds this afternoon in any one of your wonderful places, large and small, I know that mortality at St. Luke's, just like at Jefferson, at least 40% is attributable to these 4 things, right? No question. Smoking, unhealthy diet, physical inactivity, and, of course, alcohol. And we could tie back at least 4 out of 10 deaths, inpatient deaths, to these 4 things. So we got to attack this at the root. Hard to do. We're not really paid to do that, right? So again, population health would say, well, the cost-effective approach to this is not in the inpatient setting, it's way earlier in the care in the community. Now, from a policy perspective, remember those policies, the 3rd tier of pop health says policies have an impact. So the policy conundrum is, we invest hundreds of millions, actually in the billions, for NIH-type research when very modest amounts go toward chronic disease, care coordination, even, of course, there's no CPT code for care coordination. So this is a core problem that we face, and again, part of the policy challenges that we're working on. How about that war on cancer? A lot of people looking around the room, you remember President Nixon, right? 1972, declaring war on cancer. We've probably spent, we're not exactly sure, somewhere in the hundreds of billions of dollars now on this, when the core social change that smoking is gross, yucky, has contributed the most to cancer death reduction. The tipping point was making smoking socially unacceptable. Now we have those temples of technology doing unbelievable genetic level research in Pennsylvania and in Philadelphia in particular. I wouldn't argue with that, but in terms of return on investment, the biggest return has been on smoking reduction. We're still at 25% in Philadelphia, much better than where we were even a decade ago. Other part of population health, this is exclusively for board members, so hold on to your hats for a moment, because I have to set you up for this. So this is a full-page advertisement in AARP magazine. Regrettably, my wife and I are now regular readers. 52 million Americans read the AARP magazine. Really, the most recent issue, Susan Sarandon is on the cover. She's 55. God, it's scary. Anyway, so colleagues, you could read this, the power to fight advanced prostate cancer, turn it on. So for our clinical colleagues, you recognize this, of course, is an ad for Provenge, which is immunotherapy for advanced prostate cancer. Now, this is not a clinical conference, but here's the conundrum that we face. So this is a full-page ad in the AARP magazine to stimulate readers to go see their doctor to say, I'd like to get Provenge. Now, Provenge is a relatively new therapy, recently approved, paid for by Medicare, immunotherapy for advanced metastatic prostate cancer, horrible disease. You get 3 infusions of this, and it's $33,000 per infusion. So it's $100,000 for a course of therapy. The best research evidence says it extends life 4 to 6 months. So today's not the day to discuss the ethical and moral implications. That's not my point. My point is, this is a full-page ad in one of America's most widely read magazines that is inducing demand for a very niche product that flies in the face of the best available science? Should we be screening for prostate cancer? What could we do with resources that could be reallocated instead of $100,000 per course of therapy? What could we do with that in the community to improve our quality of life score? That's the question. And this is where, if we don't engage in this conversation, editorial comment, if we don't engage in this conversation, well, then we deserve more rules and regulations that, we didn't write. In other words, I am of the view that the answer to the riddle is in this room, in part, that we should be engaged in the conversation. Okay, let me leave part 2 and say to you, of course, one word that will save your life, and that one word is no, of course. No, Ma, you didn't need that third CAT scan for your hiatal hernia. By the way, Thanksgiving that year, when my mother flew back up to New York to be with my brother and me, I said to my kid brother, shut the light, let's see if Mom glows in the dark. Scary. Okay, we're going to skip this and go to part 3. All right, so in part 3, now I have to lay out, well, what exactly is the cornerstone of reform? I'm going to give you the answer in a moment up front, and then we'll transition to part 4, the future. So here's the answer to part 3. Health reform is all about 4 words. All you got to remember, here it comes. No outcome, no income. One more time. No outcome, no income. That's your strategic plan. I mean, you've said all this, but I'm just making it even easier to remember. So it's all about being paid based on the outcome of what we do. And we're already touching on that. Central line-associated bloodstream infection, readmission rate, decubitus ulcer, sentinel events, all the blocking and tackling we've got pretty good at in the last 5 years. Now we're headed to a new world of what are you doing in the hospital in the first darn place? We got to coordinate all that care outside the 4 walls. And board members, it's a new world order for governance responsibilities because your purview will extend outside the 4 walls of the hospital. Okay. So now I've set you up for part 3. What is reform all about? I'm going to show you this in a way I think you've probably not seen before, I would guess. And then not political conversation. We're not going to talk about the exchanges or any of that other nonsense. Did the bill do what it's supposed to do? Important question. Hit me with that when we do the question and answers. All right, so here's the question for part 3. Are we at the tipping point? The Malcolm Gladwell social change. Are we really ready to do this? I don't know the answer. But this is still my favorite book of all his books. Are we really ready to say, okay, no, we don't hire smokers. Or, no, your BMI, you're going to get a phone call from the school because your kid is fat. A lot of parents don't want to hear that. And, no, not a good idea. Look, we tried to take cheesesteaks out of the hospital cafeteria, and the union went ballistic. Right? I mean, cheesesteak is religion in Philadelphia. But you see the disconnect? We have nurses, our largest single employee segment, most of whom on average are over 46 years old now, and a large percentage of them are smokers, right? Who are we kidding? Are you ready to tackle that? That is the tipping point, And I'm not sure. I'll let you sort it out, see whether you're ready to, engage with this. Okay, so here's the team. This is an update for 2 or 3 pals I have in the room. Okay, so here's the boss. And these are my fraternal twin daughters and my 23-year-old son. So this is Esther, Leah, Jacob, Rachel, and David. We got the entire Old Testament pinned down here. So we're a healthcare family. This I got to brag for 1 minute. This gets me ready to talk about health reform. So my wife and I trained in internal medicine together, 2 different medical schools, but we were house officers together. She's a managed care executive. My daughter Rachel is a senior in medical school at George Washington University in D.C., now deciding going into medicine, thank goodness. Her twin sister, this is ultra cool, has been working for the last few months, her first postgraduate school job at the Center for Medicare and Medicaid Innovation at Medicare headquarters. So I have a daughter inside the belly of the beast. How cool is that? And Jake, I'm so happy to tell you, he graduated in May. Then he worked on a farm. Then he went to Nashville to do a gig with some pals. And then the boss and I said, you're out of money February 1st, and I want you to come home. January 15th, he got a job. Unbelievable. Unbelievable. You can't make this up. I mean, Scout's honor. January 15th, the night before his 23rd birthday, I get the phone call. Dad? Yes, Jake, where are you? I'm in Denver. Oh, that's great. Did you get it? I got a job. I'm so excited. I said, why are you so excited? I said, I'm excited because that car you're driving, I want you to bring it home if you didn't get that job. So he's at a cool company called Welltok, T-O-K, W-E-L-L-T-O-K, an online, high-tech, very cool patient compliance and reward company, privately held, very cool. He's been there 3 weeks. He said to me, tell me about that stock stuff. What does that mean? 3 weeks on the job. That is his whole generation. 3 weeks. Could I have my options now? It's time to cash out. Unbelievable. You can't make it up. You really can't. All right. So you get the picture. The Nash family, healthcare is the family business. That's really the message. All right. So now here's reform in a way you've never seen it. So reform has basically 5 pillars, and it's all about the quality infrastructure and manipulating the economic incentives in the hope of improving quality and safety and achieving higher value. It's a gigantic social experiment. There's some solid research on aspects of this, but no country of our size and scope and our complexity has ever really tried this. And I won't get into all the gory details, but kind of important. So there is a 25-page document, the National Quality Improvement Strategy, March 2011, which I hope you've read, that articulates how AHRQ, FDA, HHS, PCORI, and all the other Washington groups will articulate to measure and improve quality, super important. Second pillar is quality measure and development. With your ACO, there's roughly 30 new, largely ambulatory quality measures. How are we going to do that? Still not exactly sure. Number 3, value-based purchasing. Well, we've been in that for 5 years. That's the no pay, no outcome, no income that I alluded to. Prevention and wellness. I'll show you 2 slides. So now every Medicare beneficiary gets a, quote, free annual preventive visit. Well, it sounds great, but you and I are paying for that free annual prevention visit. No co-payment for a colonoscopy, no co-payment for mammography if you're over 65. That sounds swell, but somebody's got to pay for it. And then the 5th tier, these new entities, like where Leah Nash works, the Center for Medicare Innovation. If there ever was an oxymoron, that is it. But okay. All right. So, not going to read this. This is core stuff that most people don't realize that the bill covers. Well, there's a lot of prevention and wellness in this thing, which is probably good. Hundreds of millions of dollars, not billions, hundreds of millions, roughly 500 million, devoted to the prevention and wellness strategy and the prevention strategy. So, great. I'm all in favor of giving, mom an incentive to, not smoke, not her biggest problem. But at the same time, if we give mom Lipitor, yikes, we're blowing the whole savings here. So we've got some stuff to struggle with. Okay, but here's the core. The core is, I could describe all of the payment system with really one slide. So I'm going to set you up with this, and I'm going to show you a diagram that illustrates each of the 4 boxes. So these are the 4 cost containment strategies. Let's quickly go through them. And if you don't get it on the first try, don't worry. Then I'm going to show you a picture to illustrate each of the 4 boxes. Take-home message. No outcome, no income. That's the message. All right, so you already got that. Now let's go through each of these. So number 1, we got to tie payment to evidence and outcomes. Okay, great. You ready for this? So I envision very soon, like next year, every doctor who works at St. Luke's will have their PQRS scores online. Just go to cms.gov. There's David Nash and my office PQRS scores. If you don't know what I'm talking about, you ought to. So transparency and accountability, 1918, driving evidence and outcomes. That's box 1, already here. Kind of snuck up on us. Box 2, bundled payment. I'm going to show you a picture of that. Bundled payment, okay, here's what that is. That's capitation in drag. That's capitation from 1994, 5, and 6, coming from California, back to get us. But the difference this time is it's got subspecialists involved, not just the primary care poor doctor gatekeeper. That model's gone. The bundled payment is heat, light, electricity, the hospital, the clinic, the network, the nursing home, wherever, one lump sum. Your job, how do we allocate the bundle? More on that in a moment. Box 3, reimbursement for coordination of care. Well, you know, when David Pate and I were house officers, here's what the discharge process looked like. Mrs. Jones, here's your prescription. See you later. I mean, he's laughing because it's accurate, right? See you later. The discharge process today, come over here, takes an average house officer at our place 25 minutes. Here's your prescription. Here's your follow-up appointment. Here's your nurse care manager. Here's the doctor's office and address. Here's the ambulance company that's going to use the bus to take you to your first appointment. Why? Because if she comes back in the next 30 days, it's our money at stake. So we haven't rewritten the textbook of medicine. We're just now getting paid to coordinate care. Board members, now you got to start thinking, well, where do these people go when we discharge them? And how do we keep them in the St. Luke's family and keep them healthy? Oh, boy. And then box 4, I know you're in an ACO. I'll show you some examples of where we got to go in the future. Okay, so let's quickly go through these. We're going to move from left to right, no politics intended. When we go from left to right, you and I assume more economic risk. That's the goal. So you're already accustomed to these pay-for-performance programs. We have one with our local Blue Cross plan. It's largely process-driven. Did you order the hemoglobin A1C? Did you check the urine for protein? Did you get the eye exam? Did you do the lipid profile? You know, great. We're doing better with this. Okay, it moves the ball, you know, a couple of yards. If you can't do this, you got no hope for value, so this is the baby steps. Certainly you don't want to ever have a never event. So board members, let me remind you, the journal Surgery, February 2013, 80 plus wrong site surgeries a month in our great country reported to the Joint Commission. How could that be in the 21st century is a head scratcher. How? Easy. No just culture. Oh, our nurse petrified by your biggest admitter, who's a son of a gun, and she saw that the film was backwards on the view box, wasn't going to say a word. That's how. So you better be able to do that. If you want to practice population-based care, you better have that just culture. This is how we do it here, based on the best available evidence. Not easy. Not easy. We already covered that in part 1. Okay, let's keep moving. Episode of care. So this is the bundled payment. Let me show you. You've seen this before. So we got like 35 million people are in some kind of bundled payment. It's typically right now for procedures, hips, knees, hearts, transplants. But eventually, we're going to get that bundled payment for heart failure. Oh boy, how are we going to divide that up? So here's the message on bundled payment. It's probably working because it's got that capitation sort of feel to it. Here's the lump sum. You figure out how to allocate it. So here's the message for the board on the bundled payment. As the size of the pie shrinks, because there's no new money, we're not going to get a greater amount of money in the next 4 years for Medicare. That ain't going to happen. So as the pie shrinks, the size of each piece gets smaller and smaller, right? The total pie is shrinking. As the pie shrinks, table manners will deteriorate. Now, for doctors, let me look this way. As that pie shrinks, you know who I'm talking about. Admit to 3 West, consult the usual, echocardiogram, Q day. Making any sense? Sound familiar? Right? You think that you're going to be able to deal with private practice fee-for-service doctors in a bundled payment world? What are you smoking? Not going to happen. This is going to mean protocols, evidence-based practice. At St. Luke's, we've evaluated what works and what doesn't, and here's how we treat heart failure based on the best available evidence, not the way you were taught 30 years ago. That is going to take senior physician leadership to implement. So while the bundled payment is an economic tool, the take-home message is it's a behavior change tool on the doctor's side. Oh boy, hard work. Listen, David knows. When I got to Jefferson 24 years ago as a faculty member, I was 6 feet, 2.5 inches tall. Right? Dangerous work. Who wants some guy saying, no, you can't do that? Right? I mean, it's aggravating. Here's the evidence. And it makes it even more aggravating. Okay, medical homes, I know you're into this too. We have one at our place. We're super excited. We have 750 medical school faculty, 50 are primary care doctors. I mean, you know, we got a right ear, left eye. You got a right eye problem? He's down the hall. So this is the medical home structure, and you've seen stuff like this, but let me hit the things that are relevant. So in our day-to-day, how I was trained as a primary care doctor, everything revolved around getting to see me. 7 minutes, that's all you're going to get. It's all about getting to see the doctor. And of course, you saw the front page Wall Street Journal story, right, this week, Tuesday? If you didn't, man, that's an awesome story. Laura Landrau, front page B-section story on the teamwork of the new doctor visit, right? The nurse practitioner, the physician's assistant, the pharmacist. Awesome, that's the model. One problem with this model, Rachel Nash's curriculum at George Washington University Medical School looks exactly like the curriculum Esther and I had 40 years ago. So I don't know whether in WWAMI they're building the doctor you're going to need. My hunch is probably not. Right? Who are we kidding? In a survey last year of family medicine house officers upon graduation, they asked, would you like to lead a medical home? What do you think they said? No freaking way. What is that even? Lead what? That's not what I was trained to do. This is a fundamental cultural issue. So while it sounds sweet, and we could line up those NCQA measures, and it's not rocket science to get accredited, the core problem, don't kid yourself, is culture and physician leadership. More on that when we get to it. All right. So the healthcare team must be led by physicians. Awesome. I would agree. If they're trained to be a leader. Not something you learn in medical school or residency. That's our deep secret. Doctors are captains of the team. Here's the team. We don't know each other's name. We never practice together. When we get out on that field on Sunday, we're going to whoop their butt. That ain't going to work. Okay, and then finally, oh boy, ACO, you're in one. Medical Shared Savings Plan. I could barely say it with a straight face. But, you know, editorial comment, who are we kidding? I mean, right? Medicare's determining your savings ratio. So next year and the year after, they're going to write the rules different. At least you don't have a downside risk, so it's good to practice. I get it. But, you know, hello? So let me show you what an ACO is really all about. So you all read Health Leaders. It's a wonderful cover story. Our school was featured in this story, too, about the analytics we're going to need. So you don't even have a computerized physician order entry in all your sites. You don't have an electronic medical record. It's a free-for-all. So you're going to need the technology, and whether it's Epic or whatever, I don't care. But you're going to need the technology to enable Dr. Nash to come in my primary care office, turn on my laptop, and be able to answer the question, how am I doing? A question that previously we never really ever had to ask, number one. And number two, since I'm going to get paid based in no small part on how I'm doing, we got to have the technology to be able to answer the question. How are my diabetics faring relative to a regional, local, regional, and even national benchmark? Bingo. Now we're ready to practice population-based care. I hope I live to see it. Let me show you some examples. And I don't have any economic interest in this, but how cool is this? This is the FITEL Population Benchmark Report, doing exactly what I just said. We don't have this yet. By the way, our electronic medical record, is so aggravating from a doctor point of view. 6 clicks to sign a chart, it's incredible. And you're looking at the patient, you're looking at the screen, you're looking at the patient. I get it. We're not there yet. Hasn't fixed what's broken. But what I do know is we're going to need some kind of registry function to practice population-based care. I have to be able to say, here are all the patients with diabetes, all the patients with heart failure, all the patients with chronic lung disease, all the patients who've had community-acquired pneumonia. We're going to have some kind of tool to organize our approach. Otherwise, we might as well just be practicing like I'm doing right now, the same way I did 30 years ago. Here's another screenshot. This is Synapse in their tool. And you can't read the details, but how cool is this? This is, all the patients with heart failure, all the patients with lung disease, their utilization of tests, and how you're sort of compared to a regional benchmark. That's cool stuff. That's what we're going to need to really practice population-based care. Okay, you get the idea. Okay, another thing David didn't tell you, so mea culpa. So board members, I am on the board of a small company you may have heard of, it based in Louisville, Kentucky, called Humana. So Fortune 72 company, market cap north of 80 billion. Our stock is at an all-time high. Here's our ACO with Norton Healthcare. This has nothing to do with Medicare. This is a commercial ACO pilot with Humana employees. There's 51,000, about 20,000 are in this thing. In Louisville with our clinical partner, Norton Healthcare, community-based hospital system. Details not important. I just want you to read these 3 core principles, right? Exactly what we've been talking about. So the 3 core principles of the Humana Norton ACO are integrated care delivery, cool. Define patient population and measure, got it. And pay for results based on improved outcomes and cost. No outcome, no income. Are you ready to do this? What if Humana landed on a helicopter in Boise and said, woo, we're ready to deal. But the price is total transparency in everything you do, inpatient, outpatient, against a national benchmark. And that's where we're headed, right? So, okay, what will that mean? Well, again, to me, it's a complete culture change at the bedside. That's really, when you boil it all away, that's what it means. More on that later. All right, board members. Closing piece of part 3, it's all about driving population health through the ACO type model. And whether we call it ACO or banana, I don't care. The Berwick vision is the ACOs will rescue us. Not going to happen. By the way, do you know what ACO really stands for? Maybe you've heard this gag. Awesome Consulting Opportunity. So the ACO model, great. We're sort of getting our feet wet. I'm glad you're in one. But we got a lot of hard work to do to make this the core of what reform is all about. Okay, let's get to the next part of our time together. I'll summarize where we are. So among the things that I think we need to be thinking about as we move into this population-based type of care, I call this my lucky 7 list. So number 1, what about your own employees? Well, at Catholic Health Partners, 35,000 employees, Humana, 51,000, Jefferson, 9,000. This is really, really important challenge that we're going to have. So part 1, what about our own people? Part 2, keep the people who are already healthy, healthy. So this is the work of D. Eddington and others at the University of Michigan. Really important concept. Got to keep the healthy people healthy, too. Number 3, patient-centered medical homes. I get it, you get it. Who will lead these things? That's the core question. That's a board-level governance decision to allocate resources for training. Registries, we hammered that. You're not there yet. You're making progress, but you ain't close on the registry function. Retail clinics, so you don't have too much of this in your market. It's huge in the East, right? So 6, 7 years ago, Take Care, Minute Clinic, we were all fighting them, hoping they would go away. Put some steroid cream on it, it'll be gone in the morning, you know. Now they're our best pals, because if we could triage the really not sick to these visits, great. The pediatricians fought these like crazy. Are you open at 6 a.m.? I love the pediatric offices where the staff goes on lunch break and they put the phone on and the time when most working people can call the office. Is that patient-centric care? You know it's not. And they fought tooth and nail the private practice pediatrician's story for another time. Managed care partners, I already alluded to that. If Humana landed in your market, what would you do? Would you run? Would you partner? Important question. And number 7, my hobby horse, none of this is possible without leadership training. Who are we kidding? You want leaders? Pay for their training. It's really straightforward. We'll come back to that. Okay, so let me turn to the last part of our time together. I hope you enjoy this. Raise your hand if you've done this. Right? Okay. So I'm watching the clock. Fortunately, we have a half hour of question and answer, so I got a little buffer here. So let me go to part 4 as advertised. Where are we going? What's the summary? I'm going to skip this in the interest of time. Okay, so a couple of take-home messages, and then we'll talk about some squirrely stuff for the future, and we'll have plenty of time for questions and answers, too. So every doctor is a leader. The power of the pen puts them in that role. And so board members, here's the couple of key closing questions. What resources are you allocating for the system to give David the wherewithal to build the physician leadership class that you're lusting for in 2014 and you're going to need in 2015, 16, and 17? Now, does every doctor need a master's degree in quality and safety? You know, that'd be awesome. I don't think it's realistic. So I would just urge you, like Iowa, Oxner, Scott and White, Texas Children's, these are the 4 that I'm involved in, who have robust physician leadership training programs internally. And they're building the David Pates of the future right now. That's what I would argue. That's your responsibility. That's a governance decision to allocate the resources. Here's the CEO checklist that you're going to hold David accountable to. You've seen this from the Institute of Medicine. It's not complicated, but it's got all the core components. And we won't take time this morning, but it appears to me that you're tackling almost every one of these. So kudos on that, as we talked about earlier this morning. Okay, so here's the president of your medical staff. Right? So let me leave you with some take-home messages, right? Major themes moving forward. Review. Transparency and accountability. If you're worried about transparency and accountability, you ought to be. Let me let that hang in the air for a moment, right? If report card time in your house was a time of angst rather than a time of celebration, then you've got a problem. You know exactly, every parent knows exactly what I'm talking about. And part 3, no outcome, no income. Now, how do we get there? Summary slide. Okay, not easy. Every one of these is a lifetime's worth of work, pretty much. Number 1, practice based on the best available evidence, 1991 definition of quality. You cannot do population-based care till you lick number 1. Can't be done. You can't get to B till you do A. Number 2, reduce unexplained clinical variation. At St. Luke's, we've studied the best way to treat heart failure, and this is how we do it here. And we're sorry, Dr. Nash, but you need remedial work for the next couple of months to understand the St. Luke's approach. And in another year, when your credentials are going to be reevaluated, we'll make a final decision. At the Everett Clinic in suburban Seattle, every doctor who they hire is on probation by definition for the first 2 years. Do they all survive past year 2? No. So are you prepared to do that? Number 3, reduce slavish adherence to professional autonomy. It's a fancy way of saying, this is how I was trained. I know I'm good. Just ask any faculty member at Jefferson. The truth is, when we see the actual data, that ain't the case. Continuously measure and close the feedback loop. You're going to have presentations on that today and tomorrow. Great. And then finally, engage with patients. Now, we have not explicitly talked about that, so I'm going to use chair prerogative, take 6 extra minutes to talk about number 5, which is, in the population health world, we're going to need to engage with patients. Let me set it up for you. So you saw Leah, Rachel, and Jacob, right? So Jacob lives in Denver. He's going to move to Boise. Got a better job. Awesome. Off the payroll, double awesome. Now he'd like a doctor because he faced this decision in Denver. He fell on the ice and cracked a rib and, gets on the Skype phone with my wife. Oh, I'm dying, Ma. Great. Now he's got to find a doctor in Denver. Let's just say it's in Boise. How exactly do you do that? Let's remember a couple of things about who we're talking about. We're talking about a 23-year-old guy. There is no known measure of time short enough to measure his attention span. He's your future patient. Right. You think he's going to call a 1-800 number to make an appointment? Forget it. If you're not online, you don't exist. How cool is your Facebook page, your Twitter feed, your blog? If it's not cool, he ain't coming to you. No way. Now, Leah and Rachel, as women, head of household with regard to healthcare decision making, so they're 26. By 35, married moms, they're the bosses. That's your future target audience. How are you going to engage with them? Let's just remember a few things about Leah and Rachel, right? So they grew up, since they're 10 years old, email, cell phones, the world's knowledge at their fingertips. You really want to have some fun with folks at that age? Here, I got a couple leading questions for you. Ask them to explain the Dewey Decimal System. Or my favorite, discuss with them writing a check for cash. You want to really have a good dinner conversation? Yeah, I'll get into it. So it's all about mobile applications, connectivity, constant conversation. And for Leah Nash, who you saw, if the background color of your website is not pleasing to her, it's over. You think I'm kidding? I am absolutely, deadly serious. I'm so serious that Humana, we're putting billions with a B in exactly how to do this. Because we know that's the future. And if we're going to ever cut costs and practice population-based care, you can't do it without the population engaged with you. Let me show you some stuff, what I mean. So here's Primary Care 2025. I didn't write this. It's a great report from the Institute for the Future. So here's let me just get to this because it's so cool. So here's your digital coach. So this chick's an avatar online. David, you're eating too much fat. Where'd that voice come from? Right? We've watched your last 3 days of caloric intake. What were you thinking? It already exists. So Eric Topol's book, The Disruption of American Medicine, it's all about implementing this right now at the Scripps Clinic. So we didn't make this stuff up. This is incredibly powerful. So I'm not saying tomorrow, St. Luke's, you're going to go and do this, but to engage with patients in the future, these are the kinds of tools you're going to need. Okay, final stuff. So here I am, occupying Wall Street. You get that, right? All right, so let me show you some stuff from Humana. I'm going to blow you away, then we'll quit. All right, so I got special permission to show you this. 3 slides right out of a board briefing book. So 5% of Humana's 13 million customers, 5% drive 41% of our total medical expenditure. Right? Now, if I did this for St. Luke's, it would probably be pretty comparable. Okay, so what's the plan? What's the plan? What are we going to do with these 5%? The answer is everything humanly possible to keep them out of Jefferson and St. Luke's. That's the business model. Let me give you something very aggravating to think about. At this moment, February 21, 2014, which stakeholder has total economic alignment with prevention and wellness? One more time, which stakeholder in the system today is totally economically aligned with prevention and wellness? Hint, it ain't St. Luke's. It's Humana. And her sister companies, profit and not for profit, right? So the Cigna, Aetna, WellPoint, and Uniteds of the world, that's the top 5, they all got the same problem. So what are we doing with those 5%? I'll tell you. We're going to drive a Humana truck to pick them up and bring them to the Humana Center in Florida, and we'll bring all the specialists to see them. We'll coordinate their care. We'll let them play ping pong. We'll feed them lunch. We'll sell them dog food, whatever it is. But we're going to coordinate every aspect. We're going to go and visit their house. See that shag rug in the bathroom? Out of there. Here's your pill box, and here's the nurse who's going to visit you once every 6 weeks, like my mother, in Senior Bridge, in Boynton Beach. Every 6 weeks, the nurse shows up and checks her pill box, takes her blood pressure, phones my brother and me. Awesome. Do you do that? Does Jefferson do that? That's what it might take. Now, imagine doing that with Leah and Rachel. Well, you're not going to fill their pill box, but you better give them some cool stuff like a coupon for the gym, or a free yoga class after work, or a St. Luke's branded yoga mat, or a nutrition consult that comes with their membership, or a free cooking class, or an online game that they could play that they find cool and engaging. Everything I just told you is already being done. So, whoa, patient engagement, this is complicated. So let me show you. Again, we don't have time, but we're moving to what's going to be called the retailization of health insurance. It's going to be like buying soap. And they're going to advertise just like, Procter & Gamble. More on that in the question and answer period. This is just to blow you away, the number of companies out there that Humana is tracking. In each of the sectors, clinical, administrative, and my favorite sector, look at this. These are just some of the consumer companies that we have our eyes on. iTriage is a Aetna company where an Aetna beneficiary could call up and say, I don't feel good, what should I do? Oh, well, if our goal is to keep you out of the hospital, we're going to be all over that. We want to know everything about you, and we'll help you as part of your membership fee. So you get the idea where I'm going with this. Okay, let's wrap up. A lot of interesting stuff coming down the road. Here's a scholarly journal called Games for Health. I'm sure you're all regular readers. There's a whole field of amazingly smart people learning how to do patient engagement. So I don't want you to leave with patient engagement as the top thing, but a huge topic we haven't really talked about till now. Okay, I'm going to skip all this. This is another cool thing. Okay, last 3 slides and we'll quit and go to questions. So let me come back to where we were. We did 4 things, right? Part 1, how do we get in this jam? Medical error is the 4th leading cause of death in the United States in the 21st century. Shame on us. Everywhere but Jefferson and St. Luke's anyway. Part 2, population health, been around 35 years. 15% of a population's well-being is based on what you and I do at the bedside. The other 85% is that messy social stuff. Part 3, health reform. Forget the exchanges, this is a sideshow. Health reform is all about using economic incentives to drive a change in clinical behavior in the hopes of improving outcome. Big experiment, we're a couple of years into it. And in part 4, whoa, no outcome, no income, patient engagement. So let me leave you with a couple of final thoughts. So here's a little bit about our School of Population Health. And again, I sure hope you'll join me in Philadelphia. You'll take all the handouts. My goal is to not carry anything back on the airplane tomorrow. But will one school fix what's broke? Certainly not. But 4 schools might, 10 schools definitely, 30 schools with all this new stuff, well, now we got a fighting chance. Sending doctors, nurses, pharmacists, board members for ongoing education in all aspects of this, well, that's great. You don't need a master's degree, so come to our 1-day program, come to our 5-day program. I'll bring it to you. You get the idea. There's lots of opportunities to engage with further learning, not just with us, but with lots of very credible places working on these issues as we're standing here. Now, I'm not going to read this out loud because it's a little ribald, but it is my favorite president. And much better to be inside the tent. That's what today and tomorrow is all about, right? Much better to be inside that tent. When I show this at a Catholic Healthcare Partners meeting, boy, did I hear from the sisters. Oh, boy. I kind of slipped past them, but okay. So let me leave you with my last slide, which is really my own personal message. So here's John Cotter, of course, one of the best brains in the business of leadership training at Harvard Business School. 30 books on leadership. So the institutionalization of leadership training is the key attribute of good leadership. Translation, what you're doing today and tomorrow, right? Leadership training. The number one job of leaders today is to do what? Train the leaders of tomorrow. That's a big deal of what you're doing, right? So let me close by saying once again, I am so thrilled to be a part of today and your program tomorrow. Looking forward to the question and answers. I'm going to be here the whole afternoon, so if you have private questions, I'm happy to engage with you. And God bless you. You're doing God's work. Thank you very much, ladies and gentlemen.
Really well done.
Thanks.